Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good afternoon, and again, welcome from Washington, D.C. This is AMGA's Filibuster in Fine Print podcast. All the public policy news that's fit to print. That's another copyright violation. That's 2 in a row. We are here with two of our typical policy experts.
Hi, I'm Daryl Drevna, Senior Director of Regulatory Affairs and was Staff Director of the task force.
You took my line.
Oh. We can fix that in post.
That's right. That's what Mike I is here.
Yeah. Jamie Miller. I have an even better title. I'm Ambassador of Goodwill for this organization.
All right. And we have a very, very special guest star.
We do.
Beth Averbeck, and physician from Minnesota at Health Partners, and an expert in everything, she tells me.
Well, depends on the day.
Okay, that's great. So thank you for being here.
Yeah, thank you. Yep. So I'm Beth Averbeck, Senior Medical Director for Primary Care for Health Partners in Minnesota, and my clinical practice is geriatrics. So I have a lot of interest in end-of-life care and supporting people through advancing illness.
All right. So we talked earlier about our macro value task force, of which Daryl is the staff director for, and Dr. Scott Hines is the chair. So a little background. For 2 years, AMGA has embarked on a effort to revise and reform the macro statute, which is basically the underpinnings of the Part B reimbursement system. Beth and Scott were part of that committee. They looked at 6 pillars on how we actually reform macro, but also how we transition the system to value more generally. And we talked about some of the 6 pillars in an earlier podcast, which was outstanding with Dr. Hines. But today we're going to focus on one in particular, which is end of life. Is that right?
Yes, end of life care.
Okay, so that's means. A really easy topic to cover.
It's going to be very light, fun.
It's right before our happy hour also, I noticed.
It is. So I timed this out very nicely.
Yeah.
So we'll bring you down further down with some depressants. And
we literally have a bottle of gin and whiskey under the table.
Well, it is AMGA.
Indeed. So why did the task force tackle end of life, and what were some of the recommendations around it? And I think, Beth, you probably have a lot of examples of how end of life works and doesn't work, and what the task force recommendations could possibly do for folks that are facing this. We all face it. So death, taxes, and healthcare.
So I think the task force is one of the early meetings, and we're talking about how can we do right by our patients, whether it's patient engagement or making sure they're in the right setting and delivering the right care in whether it's in a value-based model or a fee-for-service setting. And little snippets of that conversation kept coming back to, we have a lot of patients who are getting interventions that aren't helping them. They are prolonging suffering. They don't understand what's happening. They're not where they want to be. I hear from my patients over and over, I'd like to be at home. What does that look like? So we took a step back from that and say, okay, why don't we have a whole meeting or two just on these end-of-life issues? And that's the genesis of this chapter. And then all the recommendations we have around that were based on those conversations early on in the task force that just kept coming back to those patients that, frankly, the members saw were being failed by the system.
And Daryl, I appreciate how you mentioned sort of the series of conversations, because really end-of-life care is a series of conversations. It's not an event. And I think one of the things we think about, it doesn't happen in one episode. It's generally how do you tee it up with the patient. Even when I meet somebody first time, I do care in a nursing home or transitional care, and we start with, well, if you can't make healthcare decisions, who would? And then we start that conversation, and then as illness advances, then we start talking about, well, your illness is advancing. What are your wishes? I can't predict when the time is going to come, and when it does come, we want to support you in having the type of death that you want to have, and what does that look like for you? And then I just listen, and then I hear what people want, and I've yet to have anybody tell me that they want to die in the ICU on a ventilator with a feeding tube.
Absolutely.
Yeah, and I think, if you've spent any time in a hospital, like I volunteer as an EMT, and you see like this is fruitless, it's causing pain. It's pain for the patient. It is pain for the family. They may not realize it yet, but it's not something you'd want to wish on your loved ones. So how do you have those conversations early on to sort of shift the narrative around what death looks like Beth was saying? But then, that's all well and good from a cultural standpoint. I think there's that. But then we're talking about how do we amend Medicare statute and Medicare regulations to support those conversations and ensure that AMGA members and providers are being appropriately reimbursed so they can have the resources to deliver the right care for these patients and their families.
Yeah, and I would add, there's a lot of interest I'm glad we're doing this, but there's a lot of interest on both sides of the aisle on this issue because, first, the economic impact of the silver wave on our society and on our pocketbooks with Medicare solvency is a huge issue. The amount of spend we have on people at end of life is astronomical as well. And I think both parties either thinking about the dignity of the patient, like AMG is, or they're thinking about the spend of the patient. There's a way to address this from both sides. So I think it's definitely something we're hearing from both parties.
So, Jamie, have we moved on? I remember the ACA battles very distinctly. Have we moved past the death panel issue? Is that still part of the discussion? Or do you think we're at a place now where both parties can listen to what we are saying about end of life in this chapter?
Yeah, I think there's still concern with like government involvement and doctor-patient relationship, but the way that we're framing it, no, I don't think there's as much concern because policymakers are dealing with their own experiences with their own family, and they're like, wait a second, I never really asked my grandfather or mother or whatever what they actually wanted, and I think there's a little maturity about this issue, and I would say that a lot of our policymakers are asking us questions beyond healthcare, and we can go into more detail, but they just say, I didn't even think about the help I could have gotten outside of the hospital, and I think it's definitely a step in the right direction. It's not as boogeyman death panels, as you mentioned, Chet. That's not as big of a deal as it used to be.
I do recall that, yeah, distinctly. So, Daryl, if you could talk about maybe one or two of our recommendations, and then Beth, if you could talk about the patient perspective and the provider perspective, particularly physician perspective around those recommendations and how that would actually improve how things are being done right now.
Sure. I think there's like two different avenues that we took with these recommendations. One of them sort of hits on that cultural aspect of this that I mentioned earlier, and it was, implement outreach and education programs. So what can Medicare and, the government do to educate Americans about what their options are for end of life? How can they stand up initiatives to bring in those, trusted community members, whether it's spiritual or community organizations, to help facilitate those conversations? So the first time you have that conversation isn't maybe with a clinician you've met in the ER or something you want someone familiar to you, someone who's trusted to start having those conversations. So CMS or Medicare can help stand up an educational framework or initiative to help facilitate those conversations. So that was number one. And I think the other part of this is really adjusting what Medicare pays for at end of life. There is a hospice benefit, but there isn't a lot of support for advanced illness planning, care planning. And then that doesn't even mention, we haven't even talked about palliative care yet. I think there's a whole lot of confusion.
What is the difference?
I would defer to
Dr. Averbeck?
Yeah, Dr. Averbeck on that.
Yeah, and I can, so I'll reference just a recent patient and family that I had the privilege of caring for a while, including towards in their end of life. And this was a patient who had a number of chronic illnesses, was not a surgical candidate, and ended up with a cancer. And so the decision was made that they didn't think this patient would be able to actually live through a surgery, and they would move towards palliative chemotherapy. So getting chemotherapy in a palliative way would be, could we extend the quality of life for a period of time? And that patient received palliative chemo for a couple of years while we talked about advancing illness, and then the malignancy, the cancer, no longer responded to the chemotherapy and started growing. I saw that on a CAT scan. I called the oncologist and had a conversation with the oncologist saying, it looks like it's progressing. This patient's going to see you. Can you have a conversation? I had started talking about moving towards hospice already. Patient had some cognitive impairment, so some mild dementia, so didn't quite understand everything. So I called the oncologist, and this was, again, a series of conversations. It wasn't a one-time event. They called me back the next day. We talked about what that visit might look like when the patient saw the oncologist. In the meantime, the nurse practitioner I work with was calling this patient's spouse and talking with them to prepare them on that things were progressing despite treatment, and we were looking more towards hospice. That patient saw the oncologist. The oncologist talked about hospice, and the patient was able to return to the nursing home. The spouse was involved, hospice visited, and the patient was able to die at the facility in the room that they lived in with the staff that they knew, with their loved ones nearby. And I think that's an example of how through palliative care, then moving to hospice when we were no longer going to be checking labs or doing anything proactive because it wasn't going to help. And I think the other thing, Jane, when you're talking about sort of changing the conversation, there are a lot of things we do in end-of-life care, not just about what we don't do. I mean, so we also talked with patients about, here's how we're going to support you, here are all the things that we can do to keep you comfortable, to treat what we can while your underlying illnesses continue to advance.
Well, all these consults and communication seems like it would take a lot of time and money. Are a lot of those things reimbursed for and billable?
There was no bill that was
okay.
that was put in any. That was the right thing to do.
Yeah.
And so I think one of the things you talked about, the different payment models. I mean, clinicians just want to have the conversations with the family, but a lot of times it's not just the family; it's the specialists involved. It's sometimes the children. Sometimes it's more than one child, and so any type of mechanism that we have for payment just to support the conversations as they occur, because again, it tends to take an iterative discussions and answering questions along the way before everybody kind of aligns and we have the care goals really defined.
And I think that's one of the recommendations we have in our chapter is establishing this like total cost of care model. How can we wrap around all these services, all these needs, whether it's for the patient at the beginning of that journey all the way up to the end? You know, what can CMMI, they're interested in new models, and here's an opportunity for them to, you know, talk to folks like Dr. Averbeck and say, here's what goes into a successful outcome. Even though it ended in the patient's death, it honored their wishes, it honored their dignity, it brought in, you know, family and caregivers and the community around that person. How can we build a framework around that, you know, at one point, yes, considers the dollars and cents that needs to be part of that system, but how can we like build around that patient in a framework that supports the ability of providers to deliver the level of care that she's talking about?
Yeah, you would think CMI would be interested in that. I was impressed during the course of these conversations. The dignity of the patient came up first and foremost. And after that, how do you build a support system around that dignity? So that's really important. And so I guess, Beth, right now, there's no support mechanism from CMS or payers to help with that work. It's basically, so your group does the right thing, you do the right thing, but that doesn't happen elsewhere. So the recommendations are really about building a support system, whether it's a model that we'll push, or whether it's, I guess, financing for these conversations, which are, I hate to say it, I've been through this recently, and the number of conversations we had with the hospital and physicians and actually our clergy, it took a lot of time and a lot of patience. And so there's a lot of work around this journey. And so it does need to be reimbursed and frankly incentivized. And that's what we're talking about. Is that right?
Yeah, absolutely. Absolutely. You know, it's to Jamie's point, it's a totally different conversation than I think in our culture, there's this fear of, am I giving up? And no one wants to say, I'm giving up on mom, I'm giving up on dad. And that's not what this is about. And, you know, I think through these series of conversations, you can get out of that mindset and say, no, I'm helping them along. I'm not abandoning them and turning my back on them. And then, so there's that cultural aspect of it. And we're building a framework that reimburses the system to support those conversations, ideally.
And Beth, how do you address the cultural issues? And how did health partners do that system-wide, or is this more you?
No, I think I would say definitely system-wide. So advanced care planning and working with the electronic health record to have it in a way that can be easily visible and then verified, not necessarily like start from scratch at every care setting, because patients will go between care settings. And then to the extent that we have the opportunity to, with patients' permission and the health information exchange, be able to pull records from other systems, that helps as well. So, and then working with communities, we certainly have a very diverse community in our care system, along with rural communities as well. And so, as you mentioned earlier, Daryl, how do we work with the communities and learn what's important to them, but also have them help in the conversations, because patients spend most of their time not in the doctor's office.
That's right. Exactly. Well, that's great. I'm glad to hear you all have a culture there that supports this kind of work, because it is so important. All right. Well, I think any final comments? Final's a bad word in the context of this discussion. Any other comments?
Yeah, no, it was really, going through this entire exercise with the chapters and the task force, this one really resonated with me. It was something that we hadn't talked about as an organization as much. So I was really pleased to be a part of this, and it was a really interesting chapter to work on.
And I would just say, from the standpoint of being on the macro task force, really appreciate that this is one of the things that we discussed, and really AMG helps us move forward in normalizing the conversation. And that's really, I think, what we're talking about is, let's start normalizing this, and then we continue, and then support patients and families and caregivers along the way.
Great. And Jamie?
Yeah, I would say politically, Oregon's always been interested in this. All the members from Oregon, for various reasons, because of state legislation. So that's been great. But now we're having senators from certain states that are conservative who are very interested, because they're dealing with their patient population, and there's a lot of family stories, and they're hearing from. And a lot of these folks vote and they call, and it's becoming more and more of an issue, and it's less polarizing than it used to be. So I think it's a step in the right direction, and I applaud you all for doing this.
So, Jamie, you and Beth will be doing a lot of work on the Hill around this issue. Is that right?
Yes.
Good.
Yes. but what the beauty about AMJ is not just about cost models and everything. It's talking about how to incentivize a caretaker, or have tax incentives for a caretaker, because there's a lot of things involved, and Beth knows this better than I do. I'd love to hear your perspective, but there's a lot of non-medical things involved that we could help through the tax code and other things that we could really help. And we're in talks right now with key policymakers on those issues.
I mean, I could think I would maybe just add to that, because patients, very few age alone, and so it's all the different caregivers, people that are taking time off from work to go to appointments, or working on the systems to help their loved ones age in place. So what does that look like beyond just the medical component?
Yeah, it's a village.
It takes a village.
Village.
All right. Okay. Thank you, Jamie.
Is that the title? Is that the title of this podcast?
I believe it's also copyrighted, so that's 2 violations and what? Yeah.
Is that
So,
our producer says I'm cut? Thank you.
Yeah. So you're out.
I'm no longer associated with AMJ, so don't sue AMGA.
Miller.
Well, we were doing so well.
I know. You let me talk.
Good job, Jamie. It's been great working with you. All right. Well, we thank you for the conversation. Thank you for the work. And for all of you out there, have a good day.
Hi, this is Daryl. Thank you for joining us on this episode of Filibusters in Fine Print. Before you go, we want to recognize that November is National Hospice and Palliative Care Month. A special thanks to our members and all those who work to improve the care for patients and end of life.